Hey folks, Scott Weingart here from the MCRIT podcast. I have a real treat for you today. I'm going to debate Paul Mayo on whether video laryngoscopy should be used for every single intubation. If you haven't seen our last debate on paralytics for RSI, you should check that out as well. That's in the show notes. Before we start the debate, I just wanted to do a public service announcement. Now, I'm only going to do these twice a year, and I'm sorry for bothering you. But what you need to understand is that the MCRIT podcast works on the public radio model, meaning every episode is available entirely for free, and it's out there for everyone. It's foam. If you're a student or a resident, you never have to pay a dime. But like the public radio model, the show relies on the support of its listeners. Now, I have MCRIT CME. It's on a separate site. You pay for it. You get a receipt, and that's what supports the show. But what I need you to understand is I don't want you looking at that and saying, how much CME do I get? How many hours per dollar? The CME is not there for that. That's not the purpose of the CME site. The CME site is there so that you can make a contribution to the show that is either tax deductible or will be reimbursed through your department. That's why the CME is there. So please don't look at it as a straight dollar for credit proposition. That's not what it's about. It's about you thinking the MCRIT podcast is valuable. If in some way it's changed your practice, it's helped your patient care, you've changed something you do clinically as a result of the podcast, and that changes for the better, then please support the show. It's your support that makes it available for the residents and the students who I do not want to pay. I will not take your money. Please do not sign up for MCRIT CME if you're a resident, if you're a student. But if you have a job and you like the MCRIT podcast, please consider supporting the show. Just go to cme.mcrit.org. That site again is CME, Continuing Medical Education, .mcrit.org, and sign up. I'm going to leave you alone now. You won't hear about this again for another 6 months. Let's get right to the debate. Paul Mayo, director of the medical ICU at Long Island Jewish Hospital, North Shore Medical Center in Long Island, versus myself on the topic of should video laryngoscopy be used for every single intubation.
All right. In the next 10 minutes, I'll convince the 41% that they should be joining the pro side. Why is urgent endotracheal intubation different than all other procedures? There's much complication. 1 to 2% of people who undergo UEI by world literature today die during the procedure as a result of the procedure. That's because these people have severe hemodynamic failure, they have severe respiratory failure, a dangerous combination. They have major risk of desaturation, hypotension during the procedure. There's no margin of error in this patient population, and therefore the rules of the OR do not apply when you face off against the 450-pounder who's vomiting with a tongue the size of Midtown. Standard laryngoscopy was designed in the Mack and Miller blades. Boy, 1940s technology, great, okay. However, the Mack and Millers work well, the standard laryngoscopy approach, in OR practice. They're very effective in the hands of expert anesthesiologists. Why? Because the patients are stable in their physiology, and furthermore, they're pre-screened. So the knowledgeable anesthesiologist uses the SL for the easy cases, and the hard cases are identified, and they go into the special room, the inner sanctum, where we're not allowed as trainees to handle it with Fiberoptic. That's why it's so safe. They screen, they do the hard ones the right way, they do the simple ones with a great device in the OR, but the OR is different than the ICU. In the OR, if you can't get the tube in, turn off everything, wake them up, back out, come on back tomorrow and I'll do it with a fiber optic scope. They have a wake up, back out plan. In the ICU, you're going downhill. You can't back out. In the ICU, if you fail to establish airway, you're going to have a patient either dead or they're going to be brain injured. That's worse. The ICU team, when they depart on a UEI, they don't have any option but complete it. And therefore, the best strategy, in addition to a well-organized team, is the primary device must be idiot-proof. There's no other possible approach. Good is the enemy of perfect. So we asked in our group, could we improve our esophageal intubation rate, our difficult intubation rate, through iterative quality improvement? We did this over a number of years by establishing a rigid protocol. And then we started noticing that no matter how good our team was, the SL was a little hard to use. We got the bougies, the weird SLs, the Levitan scope. We got all these crazy things trying to solve a problem which is insoluble. We gradually realized that the SL, standard laryngoscope, is very hard to master. You need at least 100 in the OR, and that's the simple-minded moronic cases. That's not any training to learn how to intubate a person who's perfectly prepared. But I would posit that to become really proficient at SL, standard technique, you have to have at least 500. And ask yourselves, the fellows here in this room, who finishes their fellowship with 500 intubations in the field? Is there anyone here? No. If you're lucky, you get 25, 50. If you're super energetic, 100. We are training our fellows for partial competence and not to mastery level for a critical procedure. Enter the VL. Is there a better way? Let's put it to the test. So we are curious about this, and I'm sorry to spring the trap on Scott. We have data for you. It's been presented. It's going through its second rewrite, rejected the first time. Let's go over it. We run in our hands with tight protocol, some marginal risk of hypotension. It's unavoidable sometimes, but we work hard. Some of our patients still desaturate. Yes, I agree. Where's my pointer here? There it is, okay. But when you compare the rate with SL 140 serial cases with full, honest documentation and complication, I noticed when we introduced with 250 serial cases of VL, we went from one to the other on March 1st, 2 years ago. We said no more SL, only VL. So we can compare pre and post with a standard protocol on either side. It's a good, tight study. We noticed that the esophageal intubation rate went from an embarrassingly high 19%. This is because these are first-year fellows. I apologize. They have to learn. It went to 0, from 19% to 0 with a VL. And the first attempt rose to statistical significant extent from 50 up to nearly 80, and the second attempt by the fellow was pretty good. The attending only had to intervene in desperate circumstances in about the same number of cases. So we have demonstrated unequivocally that if you take a group of innocent, inexperienced fellows and you train them with a simple 30-task training VLs, they will easily learn a very difficult procedure. No PCCM fellow will ever have true mastery of SL, ever. And I have concern about our attendings as well. So here's the LIJ Gorilla UEI team in action. We notice then holding the glide scope as a primary device here. Jose is hard at work. We have, yes, a bronchoscope, of course. We'll show this in a moment. Yes, thank you. We have the laryngoscope with unpleasant odor about to be dropped in the waste paper basket. And these 4 or 5 fellows have only been trained with VL, and they're expert level within 25, not 500. On the other hand, we have Dr. Weingart, who says in his defense, I never miss. That's because he's done 3,000. I have a bailout plan. You know what it is? The VL. My resident really needs to learn on a 1943 device. And apropos to our discussion last year, let me have the curare notice that he has the laryngoscope on his mind, and he's going to use a blow dart for his curare treatment in the rainforest. Argument number one, I'm going to guess what they are. The SL works pretty well for me and my fellows, yeah. But why subject fellows to inadequate training? Remember, each successive attempt increases risk, and yeah, we got rid of a lot of the old technology a while ago. There it is. We do pretty well without it. We do better without it. I'll use my VL as my bailout device. Well, why would you want to do that if it's a better device? If you use it for bailout, use it as the primary device. Why would you want to train people to be proficient with two devices when one of them they'll never be proficient with? Just train with the better device. And why, therefore, perpetuate the culture of incompetence that exists honestly in our emergency medicine divisions and critical care divisions? It costs too much. That's specious. It's irrelevant. The stuff we spend money on, bronchoscopy, ultrasound, yes, thank you. TEs, yes, they're coming down the road. Thank you, Tip. Opaque window curtains in the Memorial ICU. What did they cost? What's a lousy VL device? Plus which, speak to your supply people to see how much you lose the SL devices. See what it costs them in terms of loss. So, I'll never go, I'll never be trained because I might go to a job where I might not have a VL. That's easy. You just say to people, I'm not coming to that job unless I'm properly equipped. You got me an ultrasound machine and I want a VL, otherwise I'm not going to take the job. Sorry. Okay? I believe in patient safety. Would you work in a unit that's under-equipped? No, so you best say, I'm not going there unless I have it. There's also an identification of the aggressor. The anesthesia people use it, so we have to use it. No, but it's designed for the OR, not for the field, because you need 500 to get good. There's no margin of error for failure. Failure will have catastrophic result. Ease of use, it wins. I've showed that. Safety of use, it wins. Fast learning curve, it wins. You standardize. It's a better mousetrap. It's a game changer. And one last thing, because I took 30 seconds to introduce the miracle of LAD's support. This is what I want to convince my colleague of today. I love my VLs. He has it on his mind. I have to train my residents not to partial incompetence, but to true mastery level. They will never master the SL. They will master the video laryngoscope. I've shown that to you. I will not train my residents or fellows to fail. And I've discovered the milk of amnesia, and I've decided to think twice about the curare, hence the propofol bottle. To reiterate, it's the best device for a very difficult procedure. Scott, do you want to repost? Okay. All right, good. I promise not to interrupt.
I don't believe you at all. Now, I already knew I had Paul running scared because he wore a tie, and anyone who knows him knows that is a unique situation. So, should video kill direct laryngoscopy? Should all intubations, this is the key, should all intubations be done with video laryngoscopy? Because that is the question, not should video laryngoscopy have a role, but should all intubations be done with it? And my disclosure is I love my video laryngoscope. I had the original VMAC when it first came out, and then I switched to the CMAC device, which I think is one of the best airway management devices out there. And I don't take money from any of these companies. But the question is not, should they have a role? It's, should all intubations be done with video? Now, Paul specializes in ad hominem attacks. This is his debate style. He doesn't argue the issues. He just goes against his opponent. I'm not going to stoop to his level. You won't see any pictures of Paul's head superimposed on a body. Now, Paul also likes to leave out or change important facts. For instance, last year he told us first pass success doesn't matter. These ED guys obsessed with first pass success. They don't know what they're talking about. This year's slides, first pass success. That's the way Paul argues. I'm not going to do that. I'm going to tell you the real true studies and facts behind this. Now, if you have a powered video laryngoscope up next to a laryngoscope, let's talk about the pros and cons of that situation.
Now, there's no doubt the video laryngoscopes give you an insanely good view. They are beautiful. You show pictures of this stuff and people buy the device because it's so beautiful. But seeing the cords or the glottic structure is not the same thing as putting the tube through the cords. And these video devices have a big problem with actually being able to intubate once you've found those cords. And anyone who's worked with these devices knows that's a fact, and the studies bear it out. Now, you have to understand, and Paul didn't make this clear, there's actually multiple different kinds of video devices out there. There's what we call indirect devices, which give you that amazing view, but don't displace the airway anatomy, and don't actually give you a pathway to put the tube, and they cannot be used unless the camera has a perfect shot. And then there's the direct devices. They mirror the shape of your standard laryngoscopes, but they add in a camera. And these two devices work entirely differently. Now, the GNYHA that Paul seems to like is an indirect device. It's a non-displacing device. If you wanted to use that without looking at the screen, you'd be lost. You don't see anything except red when you look down because it's not moving those structures. When you look at these indirect devices, they do wonderfully on the mannequin studies. They do so well, and most of them are manufacturer supported. But the mannequin studies are not applicable to the real world, and they're really creepy too. So when you actually look at human studies, for instance, this one that was just published, which was a conglomeration of a whole bunch of studies, they get better visualization, but no improvement in overall success or first pass success. And so what we actually want out of it, seeing the cords, no. What we want is to be able to put a tube through them, and they don't benefit that. They are always slower, and they always lead to more desaturation because it takes longer to try to get that tube in there. These are the indirect devices. Tube delivery is the big problem. If you've ever worked with these, you know you have to bend the tube into a U shape and pray that you could actually get the tip of that tube to where you see on the screen. It's a big problem. It's a whole separate training regimen to get people on board with this. And because people are jamming this in while looking at the screen, there's posterior pharyngeal injury, which we never saw with standard laryngoscopy. So what happens when the patient vomits? Or they have blood in their airway. These video devices that are indirect are useless. As soon as there's anything in that airway, they cannot be used because there's no way to use them unless the camera is completely clear. But it's not just a patient who's vomiting profusely. If there's a little bit of mucus in the airway and you happen to get that on your camera, you have to take it out, clean it off, go back in again, and there goes your first pass. So we've been talking about what happens when you actually had the machine there, but what about situations where you don't have a video device? For instance, the patient's being intubated in CT scan or on the floor before they get to the ICU. Are we going to put a video device in every single difficult crash cart, rather? Are we going to put a video device in CT scanner? Are we going to have one everywhere? Because Paul's training his fellows to be able not to be capable of intubating with a direct device, which is available in every single crash cart all over the hospital. So if they don't have their little GNYHA, they're screwed. And guess who they'll be calling? They'll be calling anesthesia because it's outside Paul's unit, so they're actually allowed to join into the conversation. So what about cost? Paul, knocks this out. You just need to buy one for your unit. No, if you want to use this properly, if you want to go video only, you have to buy one for every spot in the hospital. I guarantee you, no one is going to fund that. But the most important thing for me is loss of skill at direct laryngoscopy. There's going to be situations where you actually need to rescue video with direct. And we are all aware now in the intensive care world that when a patient needs a central line, the residents are incredibly good at the video game technology. They can look up at an ultrasound, put an IJ in anyone. But if you tell them the ultrasound's not available, they can't put a line in anymore, at least for my residents and fellows. They don't know how. And that's what's going to happen to DL. So oops, now what when they don't have their video device? Well, nobody ever died for lack of a central line. But if they don't know how to put in an airway, that's it, patient's gone. So why does Paul want to eliminate DL? I don't understand. I tried to think about it for the past week or so, and I came up with some reasons. First of all, Paul's a director. Now, you got to understand, directors don't do much hands-on clinical care anymore. So when you get someone who doesn't intubate very much, yes. Oh, yeah, I lied about that stooping. I'll stoop just as low as he does. When you get folks that don't do much hands-on, or you have novices at the beginning of the training, like the fellows Paul seems to train, he's absolutely right. Video devices do improve outcomes in people that aren't experienced with intubation, but they don't do anything at all with experienced intubators. So that's really the key. So if you have novices, this is a great way to go. If you have people that don't do this very often, it's a great way to go. Now the other thing is, Paul's old. I shouldn't say that. That's not fair. Your years left to live challenge. And And now, why does that matter? Now, why am I saying that? Well, you see, what the studies show is that DL is actually a near field, a near vision situation. So I'm being directed towards the camera. So when you get in there, you could only move yourself so far back before you can't go any further. But with the VL, you can just keep kicking the screen back and you'll be able to deal with it. So yes, I agree with you. VL is very beneficial to folks with age-related vision degeneration. All right, now to sum it all up, because honestly, Paul and I are on the same side on this issue, video laryngoscopy is a separate skill, and it needs to be developed, and you have to train just as hard at both. Novices do benefit from video. Experts not as much. But direct laryngoscopy will remain an essential skill for any resuscitationist. There's going to be situations where you need to know it. So here's how I bring us together and I think make both sides happy. Every ED in ICU has to have access to a device. If you don't, you're not meeting up to my vision of standard of care. You should have a video device available. Every trainee intubation should be done with a VL device because then the attendings could actually teach them because they know what they're seeing. But, and here's where we really differ, that device, that video device should be one that uses the same blade geometry as the standard blades. Now what this allows you to do is actually let the attending look at the screen while the trainee is looking directly, and they're getting the experience with DL. And if they can't see anything, you just turn the screen towards them, and now they're practicing VL. But you are now training them for both, and they need to know both, and yet you're still taking advantage of all the benefits of video. You also, if that device gets covered in a little bit of mucus, it works just fine as a DL device. You don't lose your ability to complete that intubation. So, you could choose to allow them to look at the screen or not. And the studies actually on the standard blade geometry VL devices are the ones that show benefit. Those are the ones that are non-manufacturer supported, that aren't on mannequins and yet show first pass success increase, show decreased time to tube delivery. This one was just published by Sackles in the emergency medicine literature. There's been in critical care and anesthesia as well. These are devices you want. Now, GNYHA is making a standard geometry blade. I hear it's already available out there. Those are the ones you want to purchase. Get video, but get ones that match standard blade geometry. So every attending must be skilled at DL and whatever VL device is in their department. Should all intubations be done with video laryngoscopy? No. No, they should not. You should know both techniques. They both have their roles. And with that, I thank you so much for your attention.